Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We are the 22nd chapter. Ooh, what a sequential set of days we've been in, right? Woo! So powerful. Eyes, heart, love. Welcome, YouTube. All right. Episode 59 of this book reading. So we pick up at page 341 at the bottom. Peace. I'm your moderator and narrator, Uriel Neville Riley, Master Fitness Trainer. So welcome to this peaceful part of YouTube where we read books and learn from masters. All right, here we go. The finale of chapter 22, Principles of Ventilator Care. Control versus augmented modes. There are essentially two modes of ventilator maintenance: control and augmented. Whenever clinically feasible, the augmented mode should be instituted, since the patient should be allowed to do as much as his or her own work of breathing as is consistent with homeostasis. In general, the patient should be capable of assuming more spontaneous ventilation as the disease process improves. Decreasing the ventilator rate in an augmented mode is not a weaning process. Rather, it should be considered an ability to maintain the patient at a lesser augmented rate due to an improvement in the underlying disease process. In our experience, patients maintained on augmented mode have a better survival rate than those maintained on control mode. This must not be interpreted to mean that IMV must be used at all costs. Remember, most patients requiring CMV are severely CNS diseased or are severely unstable cardiovascularly. Therefore, most patients who are capable of being appropriately maintained on augmented ventilation have an intact CNS and reasonable cardiovascular reserves. Although augmented ventilation is desirable and is an encouraging prognostic sign, one should not withhold CMV when required. Ventilator discontinuance. Since all airway pressure support is theoretically instituted for the purpose of correcting a pathophysiologic process, adequate reversal of that underlying pathology would automatically dictate discontinuance of the therapy. With appropriate maintenance and medical care, there is nothing magic about the way a ventilator can be manipulated to tease a patient away from the support before reversal of pathophysiology warrants. Although the dictionary defines the word wean as to withdraw, the common connotation of the term is to gradually tease away. This slow, gradual concept is unfortunate when applied to ventilator discontinuance. Therefore, the term weaning from the ventilator is purposely avoided in this text because, in the vast majority of patients appropriately committed and maintained on ventilators, the ventilator may be discontinued when the disease process has been adequately reversed. In our experience, over 80% of patients successfully discontinued from ventilators do not require a weaning process. Rather, they are discontinued from the ventilator within several hours. We prefer to use the term weaning only in reference to those 20% of patients who cannot be discontinued from ventilatory support without gradual maneuvers for more than 12 hours. Mechanical support of ventilation must be discontinued at the earliest possible time, consistent with patient safety. This does not mean early weaning attempts without rationale, since this usually results in unnecessary cardiopulmonary stress without shortening the ventilator course. Everyone is anxious to get the patient off the ventilator as soon as possible. What must be realized is that the shortest ventilator course is accomplished by proper maintenance for the necessary period of time. Peace, YouTube. What's going on? Yay, peace. The book lovers community, we're here reading Clinical Application of Respiratory Care. We're in the 22nd chapter. Beautifully done, masterful books for MCAT love and rest techs and nurses, OR techs, all of types. So, yeah, welcome. Happy Monday. All right. Mechanical support of ventilation must be discontinued at the earliest possible time, consent with patient safety. This does not mean early weaning attempts without rationale, since this usually results in unnecessary cardiopulmonary stress without shortening the ventilator course. Everyone is anxious to get the patient off the ventilator as soon as possible. What must be realized is that the shortest ventilator course is accomplished by proper maintenance for the necessary period of time. A major consideration for ventilator commitment and a constant consideration during maintenance is the establishment of evaluation of a working diagnosis, i.e., of the underlying disease process that necessitated the support of ventilation. The cardinal guideline for discontinuance of ventilator care is evidence of significant improvement or reversal of the underlying disease process. Peace, highest heart love. Thank you so much for reading books with us. Thank you to all the book lovers community. And welcome to the peaceful part of YouTube, live from the light here in LA, where we read books and learn from masters. So we're pushing towards 600 subs on this channel, reading books. Thank you so much for the likes and subs. We're at page 343 at the top. Numerous pulmonary and cardiovascular measurements supply objective criteria useful in making this clinical judgment. However, these measurements alone are not sufficient, and overall clinical evaluation of the patient's condition is mandatory. I will put the vocabulary in the description when I'm completed uploading. Thank you so much. No dogmatic rule or guideline can be made regarding the timing or duration of a discontinuous process. The rapidity of the process will be determined by the patient. When a patient does not maintain an adequate cardiopulmonary status with spontaneous breathing, it is essential to distinguish physiologic from physiologic causes. Oh, physiologic from psychological causes. There we go. Right. Once it is reasonably established that the patient should be physiologically capable of independence from the ventilator, the patient's psyche becomes primary, and the ensuing weaning process is aimed primarily at that factor. Estimating physiologic capabilities. The procedure of ventilator discontinuance should begin once the following determinations have been appropriately assessed. 1. The underlying disease process is significantly reversed. 2. Medic Mechanical measurements of the cardiopulmonary reserves are judged adequate. 3. Physiologic measurements of cardiopulmonary reserve appear compatible with spontaneous ventilation. And 4. General clinical examination and laboratory measurements present no contradictions to maintaining both adequate spontaneous ventilation and cardiopulmonary homeostasis. Reversal of the underlying disease process. Bottom of page 343 in the 22nd chapter, Principles of Ventilator Care. I know it's high level vocab. That's okay. That makes us better. But doesn't take away from us, right? It enhances our energy and power. Yes. That's what information does. That's why I give you time to process this information so you can soak it in. And then we stand on top of that. This is solely a medical judgment. The pathology is often obvious, e.g., pneumonia, heart failure, and readily identifiable. Often the working diagnosis is tenuous or unknown. Augmented modes of ventilation are helpful in the latter patient, since the ability to tolerate decreasing ventilator rates is helpful in evaluation of the overall process. Mechanical measurements. These have been discussed in detail in Chapter 19. Some useful guidelines are as follows. 1. Vital capacity greater than 5 milliliters over kg is encouraging. However, vital capacity often dramatically improves over several hours of spontaneous breathing. Do not rule out a trial at discontinuance for a vital capacity between 10 and 15 milliliters over kg. Chronically diseased patients, e.g., chronic obstructive pulmonary disease, quadriplegics, can breathe spontaneously with extremely limited vital capacities. 2. Tidal volumes are difficult to evaluate prior to breathing spontaneously for a period of time. Immediate tidal volumes are greater than 2 milliliters over kg are encouraging. 3. Spontaneous ventilatory rates of less than 25 per minute are encouraging. Greater than this calls for reevaluation. 4. Significant tachycardia on the ventilator is discouraging since the work of breathing will place an additional stress on the heart. Again, augmented modes may prove helpful in these patients. 5. Hypotension of the ventilator is discouraging. Hypertension must be carefully evaluated. 6. Cardiac arrhythmia must be evaluated. 7. Hemoglobin content should be optimized. In the middle of page 344, physiologic measurements. These will be discussed in detail in chapters 27 and 28. Some general guidelines. 1. Arterial blood gas measurements must be acceptable on the ventilator. 2. No evidence of acute increased dead space ventilation should be present. 3. Intrapulmonary shunt measurement should be less than 30% and preferably less than 20%. And 4. Hemodynamics should be stable on the ventilator. Peace. Welcome, YouTube, live from the light. We're in the 22nd chapter of this masterful book. Yeah. Middle of page 344. 7 steps of ventilator discontinuance. This is big, all right? So all those taking notes and in the replays and the playlist, this is one of those parts, all right? Here we go. 7 steps of ventilator discontinuance. Following is a general outline for taking a patient off the ventilator. By no means is this intended to be inflexible. However, any method should include the precautions and evaluations presented. Step 1. Psychologic preparation. Preparing. A conscious patient requires careful explanation of the procedure so that the activity will not be alarming. It's very key. The patient must understand that when he or she is asked to breathe on her or his own, the initial sensations of difficulty in breathing and shortness of breath are expected and not unusual. Forewarning the patient of the expected sequence of events results in less apprehension when they occur and reassures him or her that the clinician supervising the program is competent. The patient must never be guaranteed that he or she will not need the ventilator once again. It should be explained that this is an initial attempt and you must express your confidence in his or her ability to breathe. Do not express disappointment if he or she is unsuccessful. Simply explain that it was an attempt and there will be others. The patient must not become depressed if the initial attempt fails. So this is very key. We're dealing with respiratory care. We're dealing with patient care. And what this is showing is why empathy is so enlisted in being a light worker, a healer, a nurse, a rest tech, a doctor, because you have to prepare them psychologically. So we're going to put a pin right here. Ding! Have to be cautious and careful. This is what's best for the patient. Okay? Highest heart lung. That's step one we're talking about. The patient must never be guaranteed. Yeah. Step two, manual ventilation. The initial spontaneous breathing efforts should be manually augmented, providing a smooth transition from the ventilator to spontaneous ventilation. Yeah. The patient will see that you have things well in control and that you can breathe for him or her at any time. Step three, oxygen therapy apparatus. There must be appropriate operational equipment at the bedside for oxygen and humidity therapy. Do not discontinue oxygen therapy simultaneously with discontinuance of mechanical support or ventilation. It is unwise and counterproductive to expect. Oh, look at that. I have a new stand. It's on. All right. It is unwise and counterproductive to expect a patient to assume the work of breathing and simultaneously to meet the increased cardiovascular demands of diminished inspired oxygen concentrations. The patient should be administered at least the same oxygen therapy as he or she received on the ventilator. Some physicians advise a 10% increase in FiO2. Step 4, discontinuance of manual ventilation. The patient is allowed to assume his or her own work of breathing while the ECG and blood pressure are closely monitored. The first several minutes of breathing spontaneously are critical and demand the bedside attention of the respiratory care practitioner. Clinical evaluation of the ventilatory pattern, the ventilatory effort, and the cardiovascular system must be continuously accomplished. Any patient stress must evoke immediate and obvious recognition on your part. And that recognition must be obvious to the patient. He or she must be convinced you are aware and in control. Several short periods of manually augmented ventilation may be indicated for reassurance. The main criterion and responsibility of the respiratory practitioner during these first attempts at ventilator discontinuance are to decide whether or not observed distress is a physiologic or psychologic problem. So, distinguishing between the psychologic and the physiologic. Is it in the body or is just in the mind? Okay. See, pain. That's why they give you a pain reference, because we need to know how much it's affecting the body and where it's coming from and the mind. It's all of a part of the CNS. Thank you so much for being in the master's corners of YouTube. We are reading the 22nd chapter here. Almost complete. All right. Step 5. Assessment of vital sign changes. There are vital sign changes that should be anticipated when a patient assumes spontaneous ventilation. 1. The ventilator has been providing a slower and deeper ventilatory pattern than the patient's natural spontaneous pattern. When the patient assumes his or her spontaneous ventilatory pattern, it should not cause concern as long as the pattern is acceptable and remains consistent with cardiopulmonary homeostasis. 2. The ventilator supports the cardiovascular system significantly, so that when the work of breathing is assumed by the patient, it often requires some increase in blood pressure and cardiac rate. 3. Mild diaphoresis or sweating is a common feature and should not cause concern unless accompanied by other signs of increased sympathetic discharge or physiologic stress. As long as the vital signs and clinical changes are within the acceptable limits, they should not cause concern on the part of the respiratory care practitioner. Far more important than the immediate vital sign changes is their stability over the next 15 minutes. Step 6. Yeah, step number 6. Here we go. 15-minute evaluation. During the first 15 minutes of spontaneous ventilation, it is essential that the respiratory care practitioner remain at the bedside and closely monitor the patient. It may be appropriate to intermittently give some deep sigh breaths by manual ventilator, e.g., every 3 or 4 minutes, to augment the patient's ventilatory efforts, as well as for psychologic reassurance. If suctioning is necessary, there must be appropriate support before and after the suctioning process so that the patient is not allowed to become hyperexemic or frightened. Care, giving care again, making sure they're okay. How do you feel? Asking them these questions, taking note of it. Thank you so much for the likes and subs. I know it's super high level content. I know that it could be boring, but in the long run, this is going to help the younger generation of nurses and rep techs just having this information, being able to access it, just like all the other books along down on the playlist, you'll find we completed them. And when you show that you can complete something and do something to another level, that's a part of leveling up. Hence the channel's name, my name, Level Up. All right. Following 15 minutes of reasonable clinical stability, vital signs, blood gases, and general clinical status must be reevaluated. It is important to assess what has happened to the vital capacity and the ventilatory pattern over these 15 minutes. The blood gases will reveal the net result of cardiopulmonary homeostasis and must be compared with the mechanical work of the cardiopulmonary system so that an evaluation of system efficiency and reserve can be accomplished. See Chapter 19, we saw previously. Step number 7, support of the spontaneously breathing patient. If the patient reveals a reasonable clinical status and a stable cardiopulmonary state, his or her trial of spontaneous breathing should be continued. At this point, it is important for the respiratory care practitioner to recognize the need for adequate bronchial hygiene, as well as for continuance of oxygen and humidity therapy. Appropriate deep breathing and suctioning must be accomplished over the next several hours according to the needs of the patient and his or her tolerance. The patient will realize that he or she is now breathing on her or his own and will interpret this as a very dramatic sign that he or she is getting better. There should be attempts to make the patient more comfortable, and it must be explained that the artificial airway is still needed for some period of time to keep the lungs clear. While the patient continues to breathe spontaneously over the next several hours, the cardiopulmonary status is closely monitored and evaluated. It has been our experience that if the previously described patient is maintaining adequate cardiopulmonary homeostasis and manifesting adequate reserves at the end of several hours, he or she will usually remain off the ventilator. It is at this juncture that decisions concerning the airway and other ventilator support of the patient must be clearly delineated. Top of page 347. Failure to accomplish ventilator discontinuance. Failure of the patient to maintain an adequate cardiopulmonary status with spontaneous breathing must be carefully evaluated. Yeah. We must be certain there is no iatrogenic reasons for the failure, right? That's caused by us, by the rest tech, by the caregiver. That's iatrogenic. The mechanical device through which the patient is breathing must be examined, and it must be ascertained that narcotics, sedatives, and muscle relaxants have been completely reversed. When these factors have been ruled out and the physiologic parameters of cardiopulmonary reserve still indicate that the patient should be able to breathe on his or her own, the assumption must be made that the patient is either unable to come off the ventilator because the disease is not adequately reversed or for her or his general body reserves, or that physiologic or psychologic dependence exists. Obviously, an unconscious patient cannot manifest psychologic dependence. In our experience, most weaning problems are due to either one, attempting to discontinue ventilation too early in the disease course, two, improper ventilator maintenance, or three, pre-existing chronic disease or malnutrition that severely limits reserves. In the absence of these, the next most common problem is psychologic dependence. A few patients may have to be placed back on the ventilator at night because they are afraid to fall asleep breathing on their own. This may be a reasonable approach for several days. Psychologic dependence is a difficult problem and one that demands a great deal of understanding and patience. These individuals are in need of a weaning process in the traditional sense, i.e., the process of taking the patient off the ventilator for short periods of time and trying to lengthen the periods progressively. The problem of having to wean a patient slowly from the mechanical support of ventilation for either physiologic or psychologic reasons is a time consuming and frustrating process. Bottom of page 347, augmented ventilation and weaning. For the patient who does not assume ventilator independence readily, the techniques of intermittent mandatory ventilation, IMV, or intermittent demand ventilation, IDV, are clinically useful. These techniques hold the advantage of allowing the patient to gradually assume more work of breathing without the constant attention of the respiratory care practitioner. This makes it far more practical and far less frustrating to accomplish a weaning process without being limited by the availability of bedside personnel. There still must be appropriate intensive care monitoring, but the process of decreasing the rate of the intermittent ventilation has proved quite beneficial and has shortened the weaning process of many patients. Top of page 348. Thank you so much for the likes and subs. Man, nice. Hard love, ladies and gentlemen. Beautiful light workers. This is what we're reading. Clinical application of respiratory care. In the 22nd chapter by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, 1979 Yearbook Medical Publishers. So, here we go. Page 348 at the top. As useful augmented techniques have proved for the patient truly in need of weaning process. These techniques have been misused for ventilator discontinuance. Many physicians routinely decrease IMV rates over 20 to 48 hours, a process that unnecessarily prolongs the ventilator course. Since the vast majority of patients do not need a weaning process, they do not need several days of tapering the IMV prior to breathing spontaneously. When the disease process has reversed, they will come off the ventilator. IMV, IDV are useful weaning techniques for those patients in need of weaning process. They should not be misused to prolong unnecessarily the time of the ventilator. We did it! Chapter 22 is complete. Woo! We are the champions of reading on YouTube. That's the real deal. What? Shaking it up. Reading medical books, clean. Oh my goodness. We just cleaned up a whole nother chapter of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Highest heart love. Love to all my friends and family. Thank you so much for reading books. All my mods. Highest heart love. Shaking it up on YouTube, right? Hear the chimes. We're so balanced. We had a beautiful Your Healing session yesterday. Wonderful. magical Tamrell Hunter, the singer herself. She was so blown away. We got really in the thick of it. Man, it's amazing. I love you. Thank you so much. Look at this. Gold. Golden Healer. Father Jasper. Did it. Live from the light here in LA. Another chapter. Shaking it up on YouTube, reading books. So let's have a glass of love water. Cheers to another completion of a chapter. And love to all our friends and family who we hold dear to us. I wish you have a magnificent Monday. Can't wait. Here's some wonderful piano. Share joy. We just shared some reading. And now we're sharing love water. Thank you. I love you. Love you. I love you. I love you. So busy yesterday. It's beautiful. Thank you so much. I'm so thankful and grateful for all I have now and all that is coming to me. So grateful. So beautiful. Cleaned up. Right? Yeah. We cleaned up. Read to the people. Now we're going to go into meditation. Do some poetry writing. Here we go. Thank you. Live from LA. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. You see, I love you, Mom and Dad. I love you, Isis. I love you so much, Eagle Sunflower Wolf. Nice, hard love. I will see you soon when we reconvene in the new chapter 23, reading this peaceful part of YouTube where we read books and learn from masters. I love you. I love you. I love you. And you know it, because I love myself. Thank you so much for helping us push towards 600 subs, reading books, and learning from masters. I'm your moderator and narrator, Uriel Riley. Thank you so much for being with us and reading with us. Love to you all.